Hi everyone, just to say we'll start off in about a minute. Thank you for your patience. Just waiting for the last two speakers to join us. Good afternoon, everybody, and welcome to a webinar on In Between Home and Destination, Expert Conversations on Migrant Health and TB. It's my great pleasure and honor on behalf of the KHPT team to welcome all our esteemed panelists. Ms. Sangeeta Patel, welcome. I can see that you've joined. At the beginning, I'll just like to say that we are recording this webinar and it will be accessible on YouTube and other forums if you would like to reshare that further. I'll begin by inviting my colleague, Dr. K. Karthikeyan, who's the thematic lead tuberculosis and technical specialist breaking the barriers at KHPT, to please welcome the attendees with a short address.
Thank you, Sukriti. Good evening, all. It is my privilege to welcome you all to this interesting webinar series titled as Experts Conversation on Vulnerable Groups, Health and TB. With much respect and honor, we welcome Dr. K.S. Sachdeva, DDG TB, Ms. Sangeeta Patel, Director Health USAID, Mr. Mohan, CEO KHPT, and of course all the experts in today's panel. We from KHPT sincerely acknowledge the guidance and support which was given by Central TB Division and USAID in envisioning this webinar series. A quick and a small note on this webinar series. This webinar series, starting from today, they are scheduled in a span of few weeks. This is the first webinar. This is a part of USAID funded Breaking the Barriers TB project. Because today's webinar, as the title goes with saying, focuses on migrants in between home and destination, and our experts conversation is on migrants, health and TB. The rest of the webinars which are scheduled in coming weeks will focus on urban vulnerable groups, industrial and mining population. We invite you all to stay tuned. Thank you once again. Sukriti, over to you.
Thank you so much, Karthik. As you mentioned, we are so honored to have Dr. K.S. Sachdeva, and I know Dr. Rao would be joining us. I know he is in another meeting, but he has promised he will join us as soon as that finishes. Dr. Sachdeva needs no introduction. He has been a mentor, guide, and a great support to the entire TB program and the partners in the landscape. So welcome. And I'm going to turn the floor to you for your opening remarks, Dr. Sachdeva.
Thank you, Sukriti. All the esteemed members who have joined in. My colleagues, Dr. Karthikeyan, Sangeeta Patel, the USAID Chief here at India, Mr. Mohan, KHPT, Professor Bhagat, Mrs. Sahana Mishra, my colleague Raghuram, he will join in about half an hour's time. The Dr. Ruben. Thanks for inviting me to share our thoughts on this. The issue of migrants and TB is a difficult one. It's not that easy. I mean, we have been grappling with the issue of how to address TB in migrants, and always articulated in policy for quite some time. You look at how the program is addressing, it's still very fragmented. The approach is not a holistic one, it's still fragmented. We do try to reach all sections of the vulnerable society, which includes migrants. But we started looking at specific vulnerable populations a few years ago when our Honorable Prime Minister committed to ending TB by 2025, and then we realized that if we have to reach there, we have to have a more wider, encompassing, broader approach towards TB, and much of it was then extending beyond what Ministry of Health could do. And we realized that with Ministry of Health's effort, we could reach to a particular level beyond which to eliminate TB, we will need to enlist support of all our partners in a more active form. I mean, not a tokenistic support. So the major departure in policy is now moving away from a tokenistic support to actually implementation and also enabling partners to implement those measures. Some of the recent measures have been involvement of engagement with the community, primarily TB survivors, and then turning them, some of them, into mentors and help the program to reach the community. Migrants will remain one of those groups where we will find some leaders, path, torchbearers, etc., to lead the way. The other approach has been an intersectoral approach, reaching out to the other ministries, corporates, or civil society partners to again expand our reach. And the private sector piece was rolled out about in the year 2012. The private sector engagement initially, again, when I use the word tokenistic, prior to that, it used to be a minimal support with some little money, etc. But when we started implementing private sector in a holistic manner, we have seen the results of that intervention. From about 2,000 patients reached out to private sector in 2012. Last year, we reached out to 700,000 patients. So it's a formal, well thought of engagement which is there. Similar mechanisms are now being tried to work or being worked out for other vulnerable groups, and migrants remain one of them. One of the engagement within the migrants has been to engage with National AIDS Control Organization, because they have specific interventions in the form of targeted interventions projects. And they have what is known as TI migrants, targeted interventions specifically to migrants. So they have tasted some success with migrants in the NSCP. And we wanted to both leverage on NSCP, they are our partners within the ministry, and also learn lessons from them and then scale it up. Having said that, we realize that the problems of migrants is not that small, it's huge. The internal migration is almost a quarter of the entire population at some or the other time keep moving. And the TB treatment is HIV treatment is lifelong, so people are more invested in their own health if they get an HIV. But the TB treatment, though long, is still compared to HIV, it's just about 6 months. Even with drug-resistant TB, we are there at about 1.5 to 2 years. So most people are not invested personally in overseeing their TB treatment, and that's one of the challenge for us to how to make them invested in their own care, self-care. Within the migrants, also there is another department which is called Employee State Insurance Corporations. A lot of workforce works with those corporations, and especially in construction projects and other so-called small projects employing more than 10 people, etc. It's become a mandatory to them enroll within the ESIC scheme. So they become eligible for benefits from Ministry of Labor, and health benefits is one of them. Having said that, not everybody is able to assess those benefits, but there is at least an enabling provision for them to be able to do so. Having said that, the nature of their work may not allow them to do that. The nature of their work is that they have to sustain their livelihoods, and to sustain their livelihoods, they are bound to neglect their health to actually sustain themselves and their family. And this is where first they are diagnosed very, very late. They do not approach the system per se when they have symptoms at first. They keep on neglecting those systems. Even if they approach the system, there is a delay in diagnosis. So at every step in what we call as the care cascade for the patient, there are huge leakages. More so with the migrants, because their prime aim is livelihood, and it's not the health which they are invested in. Same holds true for their families when their wife and children are also working on the same projects. We look at all of you with great hope and optimism to guide the program on how to devise formal programs for migrants, which can be context-specific, state-specific models which work well, and then the same if you try to replicate in other places, they are not replicable. Having said that, we will still look for some common grounds to work upon, where we can actually find some common elements which should be there in each and every projects, and then something added on which is more contextual and more to the needs of that particular vulnerable group. And also, when we debate on the issues, we have to think about their families back home also, because they may also have the similar issues, maybe due to poverty or other vulnerabilities. So we may have to devise some strategies. Having said that, I wish these consultations will be very fruitful, and look eagerly to the outcomes of these consultations. Thank you, all the experts, for a patient hearing, and looking forward. Thank you.
Thank you, Dr. Sachdeva, and very correctly said. I think thinking together, moving forward, collaborating on solutions, and how we can support you and the entire team should be a goal that we should be looking at. Thank you for your kind words. I'd like to move forward to Ms. Sangeeta Patel, who's the Director for the Health Office at USAID. Ma'am, we look forward to your key remarks and turning it over to you.
Thank you. Thank you very much, and thanks for having me here today. First off, good evening, and really, I'm grateful on behalf of the United States Agency for International Development to be here with you, to be really speaking, especially, it's always a hard act to follow Dr. Sachdeva, because he always speaks with such passion and commitment. So the best that I can do is really to echo his thoughts on being able to work together in partnership to find formal models really that are suitable for scale up. I think, as everyone knows, just recently, USAID hosted a webinar not less than a month ago celebrating really the International Day of the World's Indigenous Peoples. And really, it's a day that the UN General Assembly set aside since 1994 to raise awareness and protect the rights of the world's indigenous people. Today, here we are again through the support of KHPT, to focus on yet another vulnerable group, migrants, you know. And I think at least through the Breaking the Barriers project, we have a community engagement initiative, at least funded through USAID, that we'd like to see empower vulnerable communities to access quality TB services, really for the acceleration of elimination of TB. The sad point here, which is outstandingly apparent, is that with COVID-19, it's a new normal. We're facing a situation since 1947 where we've seen the largest migration since partition, you know, and migrants move, you know, for a number of reasons, but in this case, you know, usually it's for income generation, right? In this case, you have low-income households throughout India, and we've seen how poverty and really lack of opportunities drives migration. Couple that now with, you know, disadvantaged castes and also other issues related to underemployment or unemployment, lack of education, lack of other options, and even COVID-19, it just exacerbates the situation. Unfortunately, since even the 2011 census, and that's several years ago, mind you, we're in 2020 right now, migrants comprise 37% of the country's population. Now, if you factor into that even interstate migrants as well as migrants within states, it's very clear, even without the data, that a large number of people are impacted. Data from that point suggested 65 million even before COVID-19, which was like a third of the population. So we really have an issue with discrimination and a need to, you know, as the project says, to break the barriers, to be able to ensure that no matter what happens in that pursuit of employment and opportunities or even protection, that vulnerable populations such as migrants are indeed protected, that they can continue to access services, they can access healthcare delivery, diagnostics, treatment, education, and other support services, indeed, even through the government of India, that's meant to be to protect them and really to provide for at least other options. Now, we know very well that we've got a wonderful opportunity in the next hour and a half, you know, to really discuss solutions along with Government of India representatives, health and behavioral experts, as well as community members. One thing that USAID is very proud of is that we published a new policy on promoting the rights of Indigenous people. And with that, we hope we've at least set up a construct to design and manage programs that are, you know, really through the lens of vulnerable populations. So when we do design programs and we especially look at what may be impacting the livelihoods or even the, you know, the patterns of behavior of migrants, we like to promote direct engagement of migrants in those designs. So I hope in this particular scenario, as we talk about solutions in the 3 different panel discussions, that it comes out even more to understand and put ourselves within the perspectives of the folks that we're trying to benefit or serve and really structure the programs accordingly. I think Dr. Sachdev really highlighted it best when he said, look, you know, we're here to show that through an enabling environment, being able to provide quality services, but also being able to promote options that are available, that people's health is not neglected, especially migrants. So I can only hope and really pray that today's dialogue helps us to think about thought-provoking, innovative ways that we can not only inform, but really help migrants and really help to move into that domain where they are supported and where really we start to reduce these barriers. So I'm looking forward to the discussion and really excited that USAID is able to participate. Thank you.
Thank you so much, Ms. Patel. And just adding to what you've so brilliantly spoken about, breaking the barriers also aims to leave nobody behind. And on that positive note, I'm going to invite Mr. Mohan HL, who is the Managing Trustee and Senior Technical Advisor at KHPT, to please set the context for this critical conversation. Over to you, Mr. Mohan. You're on mute, sir.
Thank you, Sukriti, and also good afternoon to everybody. And it's been a great talking by Dr. Sachdev and Sangeeta Patel. And I want to give a little bit of a background. First of all, I'd like to thank the expert and the participants. You have taken time out to participate in this important discussion today. And also, I want to acknowledge USAID, CTD, and all other partners and my KHPT colleagues. Actually, they are working hard on this, actually organizing and putting the entire session for today's discussion. I also like to thank all of them. And as you all know that KHPT is working last one and a half decade in the health space, specifically in the TB last 10 years, we had done a lot of work in different sector. So, but in the KHPTs, one of the main agenda is to empower the communities. In that too, focused more on the vulnerable community. That is what we try to do end of day with the motto of reducing the inequity in the health. So that with that motto, actually we are working in the overall health space. If today's discussion, for me, it is a stepping stone for actually derive some kind of a strategy and understanding of the migrant issues, which we can really take up for our own intervention in the coming days. So in last 10 years, KHPT worked on different TB-related projects. I think many of you may not be knowing that we called maybe with the private sector called MBPH, PPI project, and also recently we are concluding the Tali project and also G project. And many of these projects are supported by USAID. And each of the project, our approach was getting into more in a patient-centric and family-focused kind of an approach, which we try to use in almost all the projects, and also integrating them into the continuum of care, and also bridge the gap between the private and the public sector. So with that, we did a lot of work, but now we have an opportunity to work on the Breaking the Barrier project. I think for me, for all means, this is an important project, which we are going to do for next 4 years. Here, the entire intervention, what we are going to implement is the community engagement initiative to empower the vulnerable communities. See, one important thing in the BTB project is the migrant population is the one group. Along with that, another 4 to 5 group which we are going to work on. That tribal, as earlier mentioned, the tribal group, the industries and the mining population, and also urban poor, and also plantation worker. I think with this vulnerability, we may exceed with this group as well, because this is something which we start as a more and as a learning initiative. One and also the opportunity to work with the 4 states where Bihar and Telangana and Assam and Karnataka, along with the 4 of our good partners called CARE, World Vision, and TB Alert, and the KHPT. So KHPT's vision is always to work along with the state government and also the central TB division. So whatever we try to do as part of the government system, because government will try to scale up this. So our entire agenda in this intervention to create a model which is sustainable and scalable. So we try to understand the behaviors and the barriers of these of the vulnerable community, and try to put out some kind of learning and the model, and scaled up through the government intervention. So coming to the migration is not something very new to us. I think it is generation together migration exists, but for the different reason. But the phenomena is changed because of the unemployment, the poverty, and so on. People started moving for their own livelihood. To give an example, like earlier, KHPT did a large-scale intervention of HIV program. Dr. Sachdeva was mentioning about that. We did have a project called Corridor Project, where we worked in Karnataka, especially in the northern Karnataka and the Mumbai, Karnataka. So the boundaries are for us, for not for the migrant, because they all move where the livelihood and the they get jobs. So I had an interesting journey with that program where I went and met sex workers in both in Kamatipur, Bhiwandi, Budwarpet in Pune, and different sex work locations. And almost 90% of the sex workers from Karnataka. And we are able to interview and discuss and understand the way they live, the lifestyle, and so on. So many other entitlements, whether there is any problem in getting the government entitlement, so on. And also we ask these women, can we go and meet your family and children at source? And we came back to source. Again, we met the source, their parent. But interestingly, what we observed that they have all the entitlements, eligibility in at source, but they are living in destination without any support system, and also there is no community support. It is almost living alone kind of a thing. So in that kind of a situation, when accessing any of the social and the health related facilities, it is in a really difficult. It is not only health related, there is no more other vulnerability, how their children also get into this kind of a vulnerability and move one place to another place, because that is how the generation wise they are practiced. So now, knowing this, how we can incorporate this as part of the TB program, I think that is going to be a challenge. We don't know exactly. This COVID has come out, really we all understood how it is aggravated. People are starting helpless, moving one place to another, walking 200 kilometers, 300 kilometers. So in this kind of a situation, the entire migrant population addressing the system, if you ask me, that there is nothing in place. So either they have to take it from the source, and the destination, they are very helpless. So this is a wonderful opportunity given to us by USAID and CTD. Can we really understand this population? It may be in a seasonal migration, it may be in an occupational migration, it may be in a migration for in a different reason. In the all the unorganized sector, semi-skilled and unskilled labor, all are migrant. Earlier, there was always a destination. People used to move to Mumbai, Pune, kind of a thing. If you ask me today, the metro city and the B city and C city, all cities have a migrant population. So this is that is what we also understood when the COVID aggravated. So in this kind of a situation, I think we need to come out some kind of a good model where we can really model it for the state as well as the national level and scale it up. I think with this note, I see that urban health, working with the migrant, it's an important one. I think we all collectively, we can achieve this goal, and we can give a lot of innovative models to government of India so that they can also scale up like the way HIV program has done. Thank you very much for everybody.
Thank you, Mr. Mohan, and very rightly put. I think, yes, it's a challenge. It's an unprecedented challenge, but it's also an opportunity. And we hope that after today's conversations, we can pull in some of those innovative ideas and move forward to support the government, as Dr. Sachdeva has also just mentioned. With that, I'd like to thank the esteemed speakers for the opening remarks and share with the audience that the format we are going to follow in this webinar is going to be 3 10-minute panel discussions. I'm just going to introduce our esteemed panelists. The first one, I'd like to, very happy to welcome Professor R.V. Bhagat, who is the head Department of Migration and Urban Studies at International Institute for Population Sciences Division. Dr. Raghuram Rao, we all know, but he's running slightly late. So once he joins, I'm going to welcome him as well. Ms. Shahana Mishra, who is the integrator at Professional Assistance for Development Action Pradhan. Welcome, ma'am. And also Dr. Ruben Swamikan, Chief Infectious Diseases Division, USAID. Like I mentioned, the discussion is split in 3 panels of 10 minutes each, but with every panel, because we would like this to be as interactive and a learning process, TinkerLabs, who's partnered with us for this webinar, came up with the brilliant idea that I raise a question for the audience. And there's a chat box at the bottom of your window, and you are free to leave your comments, feedback, and we are going to see what we can do with that. And at the end of each panel, either take a question or just give a readout of what your feedback is. I'm going to begin by talking about the first panel, which is focused on evolution of migration and trends. Like we've been discussing, migrants constitute a floating and invisible population. They alternate between source and destination areas and sometimes remain at the periphery of society. And the variations in migration patterns are attributed to rural-urban disparities in socioeconomic development and because of increasing urbanization. We are also aware that people from all castes migrate, but it's the socially disadvantaged castes that have been migrating in numbers and also for durations which are longer. With this, I'm going to ask the first question to Ms. Sahana Mishra. Ma'am, what are the migration patterns that have been observed over time? Ma'am, you're on mute. Sorry. Please go ahead.
Yeah, good evening to all of you. Migration is not a new phenomena in our country. It has been, it's quite a old phenomena. But what we are seeing recently is that basically we are observing 3 kinds of migrations: permanent migrations, semi-permanent migrations, and seasonal or circular migrations. Permanent migrations, they live with their family and they go back to source at times. And the semi-permanent migrants, they live alone and not without the family, and they go back to source once in a year or something like that. Whereas in seasonal migration, they migrate and then they come back to the source villages or to the rural areas or the places where they have migrated from in after 3 months or 4 months of time period. So within that, we also see that migration happens, inter-district migration happens, intra-district migration happens, and interstate migration also happens. And there are also migration happening across the overseas, which is basically for employment and for education purposes. But within the country, when we look into the migration phenomena, the interstate and inter-district migrations are rising in a scale in these times. And that is basically the male migration, which is for employment, search of employment or search of livelihoods. And if we talk about the factors, the main factors that are observed are the agrarian distress that we are observing these days, and also some of the social factors. For example, if I take Bihar into consideration, the main thing that haunt the young boys, that how my sister will get married. So dowry is one of the factor for which the young boys, they drop out from school and they go for migration so that they can earn some extra money and they can save for their sister's marriage. So that is one factor. And then agrarian distress that I discussed, land distribution is getting smaller and day by day. And because of skewed land distribution, now agriculture is no more profitable for the young aspirants. And therefore, and also climate also plays a big factor where which has made agriculture very risky and it's not profitable for them. So in that context, the migration to cities, to urban places have happening as the demand for labor has been increasing gradually with industries coming up in urban areas. And so the demand for labor is also there. So these are some of the factors which push migration. And if we see that all migration from all castes that happen, and because between the tribals and the non-tribals, what we see that in case of tribals, the migration between male and female is a little bit balanced, whereas in case of non-tribals, more male migration is observed, and that's more because of the social norms and the norms and rules and regulations that are prevailing in our society. So these are some kind of patterns we observe, and in case of migration.
Thank you, Ms. Mishra. Before I turn to Professor Bhagat, the audience question, and I'll encourage everybody who's logged in, thank you again for taking the time to do that. What, according to you, is a factor that leads to migration? It can be a sentence answer, a one-word answer, but while we speak to Professor Bhagat, it will be wonderful to hear what everybody has to say about that. Professor Bhagat, I would like to know what are some micro and micro factors or phenomena which can have an impact on migration in your understanding, sir? You're on mute, sir.
Thank you very much. Thank you for inviting me to this panel. So migration is an issue now. A lot of interest is generated in policy circle, and it goes to the incident that happened related with the COVID. When we see migration actually basically a livelihood strategy. But for some people, it is a survival strategy. And for some people, earning more and more. So both categories of migrants are there. You and me, some of are migrants, but we are not something of debate in the policy issues. But there is another category of migrants who are basically migrating for survival. And these migrants are basically seasonal and temporary migrants. And they are circulating between the area of origin and area of destination. So they may be working for 1 month or up to 6 months, or within a year's time, they keep on moving 1 or 2 times, or maybe 3 times. And therefore it is becoming a problematic challenges, health challenges. Now, why migration is occurring, as you asked me, let me tell you, in our country, we have huge agrarian crisis, huge agrarian problem. If you see the workforce composition, we have 45% workforce dependent on agriculture, contributing just 14%, 1/4 of the GDP of this country. And many are unemployed and underemployed, but working in agriculture. And simultaneously, there is a demographic pressure. So there is a youth bulge, and agriculture is not able to sustain. On the other hand, other factors are happening, that our social institutions are also changing. Earlier, labor was tied to the land through certain social arrangement, and that's the way that caste system survived, through the institutional mechanism, and a group of people were tied to the land, and migration was not an opportunity for them. So social conditions are also loosening. Family ties are also becoming weakening. And also we find that transport and communication, this has developed. So all these positive and certain negative factors all are contributing, making conducive for people to migrate as a livelihood strategy or also as a accumulative strategy. And so this, for those who are migrating for livelihood strategy, and these are the people who are seasonal temporary migrants. And as per recent NSSO, that is 2013, NSSO has done some survey on land and livestock survey. And now we find that about 55 million people are circulating between rural, urban, or rural to rural areas. So this is a huge number of people are circulating. On the other hand, what is happening at the destination? They are working in informal sector. And within informal sector, construction is a big sector. 40% of the migrant worker work in construction sector. And social security, their conditions are very precarious. So and informality, along with informality, they are invisible in the social security programs. So these are some of the challenges. These are economic challenges. These are challenges related with health. So there are push factor, there are pull factor, but again, they are not included as a urban policy and programs. And that is, I think, a real challenge, health challenge as well as policy challenge. Thank you.
Thank you so much, Professor Bhagat. With that, with those comments, I'm going to move on to the next panel, which focuses on effect of migration on healthcare services. Where we are looking forward to hearing from the panel as well as you, Professor Bhagat. Just before we start, the second question for the audience, if they would like to leave their thoughts in the chat box or any questions are, what do you think is the effect of migration, especially male member migration, on the family's healthcare needs? One of the most compelling challenges is the adaptation of health systems to migrations and mobility's new needs. We all know that. Worldwide, around 70% of people still lack social protection coverage, and about 400 million people do not have access to health services, and among them, a large number of the vulnerable population are the migrants. Hence, it's important that the adaptation of health systems to the migration phenomena understands the cost that can generate a sustainable system to respond to the services that are required by the most vulnerable. On that note, I'd like to turn to Dr. Ruben Swamikan, Chief Infectious Diseases Division, USAID. Welcome, sir. My question to you is, how are migration and TB linked? How has COVID-19 further disrupted this linkage? Dr. Ruben?
Thank you, Sukriti. Apologies. So the effect of migration on healthcare services has been pretty traumatic, to say the least. There is data which is decades old, which says that migrants are 6 times more likely to have TB than the general population. And this is pretty shocking. Dr. Sachdeva earlier mentioned that more than a quarter of the population migrate. And the 2011 census, which is almost a decade old now, tells us that it's around 31.2% of the Indian population who migrates. And so, obviously over the last 10 years, that number must have gone up pretty dramatically. And also, as we're looking in urban areas of low-income countries, where most of the migrants live, the risk of TB transmission and infection is higher than the estimated national averages. And again, a recently concluded survey of the risk of TB infection in India found that the infection rates in urban areas were consistently 1.5 to 2 times higher than what you see in rural areas. And these were in all parts of the countries. In addition, internal migrant workers are practically highly susceptible to new infections. And this could be in a number of factors, especially the predisposing kinds. It could be related to socioeconomic status, occupational hazards, chronic malnutrition, unhygienic living conditions that very constantly prevail in urban accommodations, the lack of proper sanitation. Many of you all have visited slums, you know what that is like. And of course, pre-existing respiratory infections. Migrants can also act as victims of infection and vectors of transmission, spreading the infection to newer areas, especially on reverse migrants. So there's a whole host of factors that brings all of this together. And this can then lead to large magnitude, where the continuity of care is especially problematic for populations like these, and especially because they are highly mobile. For someone like me who's been working in TB, and as do many of you all, you'll know very clearly that at least 6 months of treatment, if not more, and the migrant population is just moving. They could have just moved into the next street, or the next building, but they're just not available now. And so that loss of the patient can create a huge disaster as far as the health economics are concerned. So, for example, we are seeing larger amounts of MDR TB simply because patients did not adhere to treatment while they were on the drug-sensitive form of TB treatment. So, I think, just to put it into context, that the spread of disease to rural, labor supplying regions in India is thought to be a large cause of the treatment loss due to follow-up that happens in tuberculosis. So I think the effects of health are enormous, and as Professor Bhagat mentioned, that it changes in, when it becomes informal as they go back to their destination, it creates a lot of confusion. It creates a lot of panic for the patient. More importantly, it puts the health system in a spin because they've just lost contact with the patients. And that's the tragedy of migration. Thank you.
Thank you, Dr. Swamikan. Professor Ravi Bhagat, just leading from that, how does health-seeking behavior vary as per the socio-economic status of the migrant's family? Would you like to allude on that?
Yes, before that, let me clarify one thing, that we are not talking about whole gamut of migrants. I am also a migrant, some of you are also migrants. And this category, educated migrants are more than uneducated and poor. We are talking about the category of migrants coming from poor background, from marginal community, who are resorting to seasonal and temporary migration. Let me tell you, meaning of seasonal and temporary migration is that there is no residential change. Their residences belong to the rural area. They keep on working in urban area for some time in live in temporary accommodation, come back. So this is what, so there was a question in chat box, I am replying to that one. So educated migration is more than uneducated, but educated migration is not a problem. Now coming to this type of seasonal temporary migrant who reach at the destination, you see where they are living. They are mostly living in slum. Slum provides the cheap rental accommodation. And then they are living outside the city, long distance. And then they have to commute. Who are the commuters? You see, large number of commuters you will find also coming from migrant. So migrant, if commuting, there is a more health risk, more TB risk. So I think there is a lot of issues both associated with our urbanization process. Access to housing, access to water, sanitation, access to health facility, food, all these things are very. And in that context, migrants are not included in our program. In our social security program, you will not find word migrant in any social security programs, except in Manrega. And in Manrega, it is there that it will reduce rural to urban migration. And we have Interstate Migrant Workmen Act. That's all. If you look at any social security program, migrant word is not there. But after COVID, we see a lot of changes. Now, government immediately announced one nation, one ration card. That is very welcome. Government announced that there will be rental housing for migrant workers. This is after post-COVID. Within 3-4 months, we have seen. Government of Kerala announced Awaj Health Scheme for migrant workers. Government of Kerala announced that rental accommodation, 1,000 at rupees of 1,000 migrant workers are going to get rental accommodation. So these are larger issues of living condition, working conditions, and they come from poor background. This category of migrant come from poor background, SC/ST community, those who are migrating seasonally. And when they return, this is the category of migrant who have been affected more by the COVID, and they constitute larger share in the reverse migration that we have seen. So that is vulnerability constitutes very, very important aspects.
Thank you, Professor Bhagat. Taking the conversation a little bit back to also accessing healthcare. Ms. Mishra, my question is, who are commonly trusted, skilled and unskilled healthcare providers for migrants and their families staying behind?
Yeah. I'll start with the families. For the families, basically they do not trust much in the government hospitals or government healthcare providers. though they are right now, the ASA, the Anganwadi workers, they are more reachable to the families who are staying in the villages, in the rural areas. But if there is some kind of serious illness or some kind of serious diseases, then the family members, they opt to go for the quacks, the parabets who are available in the local vicinity. Because to go outside and to go to see a doctor, is they need permission from the family, they need permission from the husband who is staying outside the family. So therefore, and if it is the case of a woman, then they first they go to the parabets who are available within the locality, and then they probably would consult to the ASA or ASA worker or the Anganwadi workers. And if then it is not cured, or it becomes serious, then they go to the private clinics with the permission of the head of the households or the husbands staying outside. So this is the phenomena with the family members who are staying back. In the cities or in the urban areas where the migrants they live, they generally go to a shopkeeper, the drug shops, or to the private clinics, because they don't want to lose their ways in the by going to the doctor in the daytime, to the PHCs and the hospitals, government hospitals in the daytime, because they will have to forgo their wages. So that's the reason for which they generally prefer to go to the drug shops and get the treatment. Or if it is serious, then in the evening they go to the private clinics if it is affordable. Yeah.
Thank you so much. To the TinkerLab partners, would you like to share the word cloud that we've put together to understand how the audience and attendees are responding to our questions? While we do that, Dr. Swamikan, there's a question for you that I wanted to raise. Can you please share learnings from other parts of the world regarding large-scale health interventions for migrant workers?
Thanks, Sukriti. I think it's by and large the same, right? Right now, we are actually seeing in Eastern Europe, there's a whole host of migration that's happening that challenges the tenets of healthcare. And I mean, even there's no work, which means there's no food, right? And if there's no work, there's no food, there's no shelter. So I was actually watching a couple of days ago on television where people are actually lying on used railway tracks, because that's the only place that people are willing to give them. But what that has thrown up is, because they are in the thousands, the areas in which these people have migrated to, the local residents don't like that, right? And because the local residents don't like that, now suddenly you have the local residents who are up in arms regarding the migrants. So the migrants are not just facing issues that they themselves have, right? Migrating because of issues in their own country. But now when they've moved into this new country, they are now facing, adverse conditions by the people of that country. So, so it's a multi-juxtaposition of so many factors. So you've got your own issues, you've got issues by the environment, you've got issues created by people around you, right? And, it also depends on how friendly the local government is to where you've moved. There are a number of countries that are friendly. They've opened up a number of packages and support systems to enable migrants to get back on their feet, but it's not so in all countries. And so I think migrants face huge challenges. And I think, as Professor Bhagat said, the educated migration is far more, and we're not so worried about them. It is the poor and vulnerable migrants who face the brunt of all of these issues. Thank you.
Thank you so much. TinkerLabs, should we see the word cloud from the first question? What, according to you, is a factor that leads to migration? Dr. Sahana, a question for you before we move to the last panel. As we can see, the audience strongly believes that poverty and unemployment are some of the major factors leading to migration. Just want to understand if employment opportunities are affecting migration patterns, according to you.
Yes, employment opportunity is also one of the factors because in the rural areas where there are very less opportunities of employment in terms of because there are no industries, the agriculture sector has very less investment from the side of government, so there is very less opportunity for the people to get employment. Other than MG Narega, there is no other opportunity, such opportunities, and Narega is not a aspiration for every kind of people. So that's the reason for which people also migrate to cities and where all kinds of investments in terms of industries are going on, and there is a quite a lot demand for labor.
Thank you so much. TinkerLabs, would you like to show us the second word cloud to the question that we had raised to the audiences before we move to the third panel? So here we are. I know that we've discussed this, but just wanted to share it with everybody. Largely neglected, extreme, continuum of care, all things that I think we need to think towards, collaborate as partners. As Dr. Sachdeva has said, I would like to reiterate, support the government in thinking what the pathway to change this looks like. On that note, I'm going to move to the third panel. Thank you to all the speakers for being so patient and the audiences who are answering the questions. This is very exciting. It's the first time I'm doing Word Cloud Live. So it's interesting to see this. Thank you again. Before we move to the third one, there is a last question that I have for the attendees. What do you think makes it difficult for the migrants to avail the government benefits? One word answers, sentences as you deem fit. And with that, moving on to the next focus area, which is approaches and priorities for migrant population. There exist serious data gaps on the extent, nature, and magnitude of internal migration, and this in turn leads to hampering of services from reaching the most vulnerable. I'm going to start with Professor Bhagat. So would you like to talk to us about how are high migration areas in states faring in comparison with the low migration areas?
There is a migration is result of regional inequality. So regional disparity, if you look at the all source area are poor, having low healthcare facility, low level of education, high level of unemployment. So the area of origin is suffering more. But then there are some remittances going on. Those who are better section of migrants, they are sending money also. So migration cannot be seen in a uniform way. It has a differential impact. The better of migrants, they are sending remittances, which is being utilized for healthcare facilities. But these people are deprived in terms of development, and we have to think about the nature of development of the source region. Agricultural development cannot solve the problem. We have to think about rural development, where non-agricultural jobs can be provided to the unemployed youth in rural area. And that requires some sort of revamping our rural development strategy, where the good aspects of urbanization can be taken to urban area. And we have program. Our former president, Abdul Kalam, he has given the idea of Pura, providing urban amenities to the rural area. But why this is not scaled up or implemented? Now we have also urban mission, which says that yes, urbanize rural area, and that will create more job opportunity. We are talking about MSME, but whether MSME is going to invest or coming up in the rural area if there are no infrastructure. So these are larger issues of development, and the source regions are deprived, and there is a need to take up so that these vulnerable people, they will not migrate. The poor people will not migrate, but migration will keep up going because more aspirations will be there, and more educated people, they will like to migrate, but that is desirable for development. So one form of migration is desirable, another form of migration is not desirable, and that is, I think, the origin source regions are not doing well, and we have to do something for the rural development strategy to revamp our rural development strategy. So thank you.
To that, Professor Bhagat, there's a question I'd like to just raise from one of the attendees. How has the COVID pandemic affected migrants' health-seeking behavior particularly? Do you foresee a change in health-seeking behavior even after the pandemic, whenever that time
it has affected everybody. It has affected, and migrants are affected more because they lost job. They do not have that capacity to approach the private healthcare facility, and the government healthcare facility is totally geared towards COVID management. And even we find that the general, some of the healthcare provisions or some of the things have been affected, like immunization of children, greatly affected. So, and the treatment of the people who were generally seeking their treatment, they have also been affected. So it is not only the migrants, but the entire population has been affected, and migrants have been more affected because they were more vulnerable and they lost their earnings due to the COVID.
Thank you, Professor Bhagat. Dr. Swamikan, what are some actions taken by USAID funded programs to mitigate any risk posed by migration?
Thank you. And so USAID has been at the forefront in supporting the government of India in addressing these issues. And especially in the health sector, USAID India investments, support the health, well-being of migrant populations by actually demonstrating high-impact interventions in the areas of TB, HIV, maternal and child health, and family planning, which were then customized to the needs of the specific migrant communities. Now, these can range from different types of services, as I said, structuring community support services for individuals that are affected by TB, to designing primary health centers to meet the specific needs of migrant communities, ensuring that the migrant community members are trained to serve as essential health system staff. That was one of the key areas. And to support all of this, USAID has provided over $11 million in health sector assistance to help slow the spread of COVID-19 in India. Looking at how we provided care for the affected, it also included disseminating essential public health messages to communities, strengthening case finding and surveillance, mobilizing innovative financing mechanisms for emergency preparedness, and all of this in response to the pandemic. So, in addition, USAID has also helped do a lot of training, and the training was essential to ensure that quality services were being provided. Over 43,000 health workers and almost 60,000 frontline workers, and supported almost 1,000 healthcare facilities that were COVID hit to be prepared and to respond accordingly, for this support. Also, the US government supplied 200 ventilators. The first tranche of over 100 ventilators were mainly used in the different All India Institutes of Medical Sciences across the country, and at the tertiary care facilities, which was a boon to help support large number of influx of patients. In the advocacy space, I think we had a lot of social media creatives that were developed, and we have developed this whole plethora of TV champions that we have, and we use them to help roll out some of these media that we had, this media material that we had from the communities, and these were translated into Tamil, Hindi, and Odia, which were social media creatives that helped to elaborate the work and help the TV champions also provide support to the communities afflicted by COVID-19. So, a total of around 13 social media creatives were developed, and we helped develop it, also summarize it also into a poster. And through this, almost 27,000 frontline healthcare workers, including ASHAs and ANMs, helped take the message out to the communities. Organizations like KHPT who are leading this particular webinar also had a huge community engagement initiative where they were empowering the vulnerable communities to access quality TV services. And just to speak on the access of quality TV services, I think the government of India never rested on its laurels. Throughout the lockdown period, you had directives going out from the government of India to the various TV officers in the country to ensure that TV services were being provided to all patients in various forms of directives, ensuring diagnostics, ensuring drugs. All of this was happening, and it's really wonderful to see. Also, another key organization that we support established a multi-sector accountability framework, which helped to improve the environment for TB elimination by promoting a community action for accountability, right? And this took into account the issues of migrant populations, especially in the states of Odisha, Jharkhand, Chhattisgarh, and Tamil Nadu. And these help to bring back data to support actions that could help mitigate some of the issues. Earlier, Ms. Patel remarked that she said that in USAID has published its new policy on promoting the rights of indigenous people, and this helps to guide development practitioners strengthen the design and management of programs that affect indigenous peoples. And this is one of our new thrust areas that we'd like to share with everyone, to say that how do we really look at vulnerable communities differently, even though health is our forte, but it's not a stagnant population. They're a migrant population. And how do we demonstrate high impact interventions to address TB, HIV, maternal and child health, family planning, and a host of other issues that most of these people feel. So I think in a sense, USAID has been at the heart of supporting not just in India but globally as well. But in India, all of these have proven to be timely, have proven to be effective, and over the years we'll also understand how it has been effective and what the impact has been. Thanks.
Thank you, Dr. Swamikan. Just to round that off, your thoughts on how would you differentiate between migrants and urban poor?
Yeah, and I think Professor Bhagat and Ms. Mishra brought that out very well, right? To be able to say it's same but it's different, right? The migration happens from a livelihood perspective, right? And then they become the urban poor, right? And when something like the pandemic strikes, suddenly all of a sudden they're now in reverse migration, right? And so I think it's a vicious cycle that needs support at both ends. Both at the place of employment or place of work or where they're living, and of course to the destination if they're going back home. And I think that's the challenge, right? And it's not a fixed group of people, right? And migration can be within cities, across cities, across countries. So the challenge is innumerable, and health systems are not geared to suddenly take on these large populations. And so I think we need to understand that in addition to the regular populations that are available that come and access healthcare services, we also need to be really, really careful to ensure how it is that we want to ensure that patients can access services both in terms of quantity and definitely in terms of quality. Thank you.
Thank you so much, Dr. Swamikan. Professor Bhagat, before I turn to Ms. Mishra, there's a question that how does language barrier affect migrants at destination? For example, somebody migrating from Bihar to, say, Karnataka.
Yeah, language is very important because it's the way they communicate. So particularly when they migrate with their children, children are badly affected. So there are group of migrants who migrate with their children. And children are educated in their native languages, for example, in Odisha or in other West Bengal or in Bihar also Hindi, but when they come to Maharashtra, that accessibility of teaching is not there. So this is how they are affected, their family is getting affected. So far, healthcare is there. I think they are part of the network. They are part of the social network. So that doesn't affect language as such, doesn't affect access to healthcare. But there are other factors like their income or their affordability of the healthcare. So this is how within family also there can be differential impact of migration on the members of the family.
Thank you, Professor Bhagat. Ms. Mishra, what are some provisions in home and destination state government schemes and services that are available for the migrant populations? Would you like to highlight some of those for us? You're on mute, ma'am.
I'm sorry.
It's fine. I can hear you.
To me, there has been a scope for a lot of improvement in terms of schemes and facilities for migrants in destination and source states. But still, there are some, for example, like Bhopal Municipal Corporation, they have started tiffin facilities for the migrant workers. Also, there is Employment and Conditions of Service Act 1996. As per that, there has been a board for building and construction workers' welfare. So it is there in every state, and that is supposed to provide some facilities like they first of all register those migrants, those who have worked for 90 days in the last 1 year whenever they are registering. And it provides facilities of insurance, both accidental and death insurance, and then scholarship for their children's education. Then it provides 2,000 rupees cash subsidy for purchasing tools if they're plumbers or somebody like that. And then also there is provision for girl children. If the migrant workers, they have girls, then and they pass 8th class exam, then they get 55,000 of cash subsidy at the age of 21 for their higher studies or for some for their marriage or for their any kind of business if they want to start. So these are some of the facilities, but how it is going to be implemented and how if people know about it or not, so that's the question. And so the implementation part is really a challenge, and there is very low awareness around this.
So that actually takes me to the third word cloud. If the TinkerLabs team would be kind enough to put that up, please. So what do you think makes it difficult for migrants to avail government benefits? And one of the things that Ms. Mishra, you just mentioned is knowledge or awareness of what is it that they can access. Dr. Swamikan, there's a question for you that one of the factors we see are knowledge gaps for migrants at destination. You have mentioned that you have conducted trainings for health workers. Has there been any knowledge building interventions specifically for migrant workers, or would you have any plans to encourage that?
So I think in this case, the migrants are really people who benefited by the training provided to the healthcare workers, right? Because the need of the hour was such. I think, over time, we will also be able to see that. And there are a host of migrants, and our esteemed panelists also mentioned that, both you and I are probably migrants as well. And rightly so. And so, I think in some way, it's a circle that, goes around, comes around. But the support that the migrants required during the pandemic was crucial. And the services that they were seeking from healthcare facilities or from just the general public, those needed to be of good quality and good standard. And that was what we were setting out to do, to ensure that people who wanted these services actually got the best that was available. And so really, I think, directly to answer the question, I think the answer is no. The migrants were not really trained, so to speak. But I think they benefited by going to facilities that had access to these kind of quality services. Thank you.
So one of the, I think one of the things that I would like to touch upon and hear your thoughts, Dr. Swamikan, in continuation are, do you think there are any mandates for mining and industrial companies to take care of migrants or the laborers' health, especially with the focus on tuberculosis?
That was a good question. I saw it in the chat box. I think it's crucial, and I think the government has always been speaking about this. And I can speak from a TB perspective. At least two angles. One, of course, is how the government is addressing mining and anything that can cause respiratory diseases. Say quarry workers and things like that. They are the most vulnerable to get tuberculosis. In addition, now what we are doing is we're trying to work it in reverse by saying how can we engage the corporate sector who actually run these large industries, right? And can the corporates actually provide healthcare services to support early diagnosis of treatment, ensure completion of treatment while the patient is on the required drugs throughout the course of treatment, and also creating an awareness within the industry to say that if you have these signs and symptoms, come early, get yourself tested. What kind of workplace policy or workplace interventions are being made available. So these are all some of the newer areas that we're pushing. And at both ends, government is of course doing its bit to support it on the ground. And in addition, we're looking to see how we can do a top-down effort and try and understand what are the possibilities that we can address it in different ways. Thank you.
Thank you so much. Ms. Mishra, there's a question. It's actually a dual question. I'll see if I can combine it for you. So the audience definitely feel that there are schemes which are not able to capture the exact migration data from state or the central site. And obviously, because of documentation gaps, it leads to a hindrance in providing services to the migrant population. Have there been any interventions or improvements over time in your understanding in this area?
Yes, actually, there are some coalitions that have worked very well in this case. For example, the National Coalition for Migration and Security has set up centers by the name of Shramik Sahayata Evam Sabhavana Kendra, and that provides facilities. They help the migrants both at the source and the destination points. And they are run in 5 states like Uttar Pradesh, Odisha, Maharashtra, Rajasthan, and Gujarat. And they facilitate the migrants and they provide information in case of any kind of documentation if they need. And some health facilities, some emergency services. So these kind of services are provided at those Sahayata Kendras. So and over the time we have also seen, and during the COVID also we have seen how the CSOs, the civil society organizations, they have come up and they are doing a great job in case of providing help and support to the migrants. So these are some of the initiatives, and if they could be taken up strategically and by the government, so it will be a very good support for the migrants.
Thank you so much. I'm going to turn to Professor Bhagat. Professor Bhagat, I'm also very interested in understanding the definition of a footloose migrants, and are there any facilities for footloose migrants in India?
Yes. As I told you earlier that we have so many social security programs, but if you read the document, you will not find the word migrant. So if for urban area, for rural area, you read the document, except Interstate Migrant Workmen Act and Manrega, I don't find word migrant. Now it is coming up post-COVID. So given this scenario, COVID has awakened our policymakers. And now the question is, several things have been announced. One nation, one ration card, rental housing. But now the question is how it is going to be implemented. Who will be responsible? It is an interstate matter. We have GST Council, which sorts out the problems or relations between the states. But now there are states of origin, states of destination, and there is a central government. You must have seen when there was a issue that how migrants worker will be transported back to the area of origin. There were a lot of discussion who is going to bear the cost. State of origin or state of destination or central government. Then there was some formula, this, that percentage. This is, I think, real issue. Migrants belong to whom? Is it belongs to state government, origin state, or destination state, or central state, central government? And therefore, I think some way of coordination, some way of thinking regarding GST Council, we can have interstate migrant council to sort out all these differences. Otherwise, there will be announcement of portability of social security programs, but how portability of social security programs can be implemented, I think that is really. So my submission is that migrants are not included. Even there is a doubtful whether they are citizens because they are not the vote bank. When they come to the urban area, sometimes their names are not their voter list. And if their names are there in voter list, that list is there for the area of origin. And when election comes, they are not going to able to go and vote in their constituency. And therefore, they are not the vote bank also. And therefore, this is a serious policy making, some sort of structural thinking outside the programs. Program people can do this and that and make it temporarily effective. But in the long run, we need some structural policy to deal with migrants within the framework of our constitution.
Thank you, Professor Bhagat. Dr. Samikan, I know we are running short on time, so I'm going to ask you the last question because you addressed the point on COVID and its impact specifically from the TB perspective. What are some of the learnings from COVID around how best can we strategically deal with reverse migration, Dr. Samikan?
Yes, I think reverse migration is an interesting phenomenon, right? Wherever the people were, like if you take urban slums as an example, people went back home. We've been reading a lot about how when they've gone back home, those chief ministers are saying that, you don't need to go back to where you came from. You stay here, we will support you. And I think enough has been said on, social support schemes and Manrega to say, is it actually possible? And we also saw that, the moment the lockdown was lifted in certain areas, people started coming back, especially where transport was available. I think maybe this is the lesson. And I fully agree with Professor Bhagat's point on, who do these migrants belong to? Is it source? Is it destination? Is it, the central government? And I think, these are all questions that need answers. Right. And, despite, whatever formula is being used, because you do not have a denominator in what the actual number is, and that denominator keeps changing, it's always going to be a struggle for governments to provide support. And so I think, reverse migration, I think some of the things that organizations or, places where these people come back to, say the city corporations, for example, what are the plans they are setting in motion now? Right, for these migrants, right? How can they address the problem better? Right, we're looking at, people talk about a second peak. We haven't even reached the first peak, but people are talking about a second peak. So if the second peak happens, are we prepared? Right? Is there going to be a second wave of migrants going back home? Or is it possible that, we can continue providing some kind of support? I think the key really here is, the whole interstate migration is critical, right? We've got to really understand how this interstate migration was already precarious, and now it's just gone off the edge, right? And so we've just got to ensure that the inadequacies that we're seeing in the health system, that we need to find ways to diagnose, to treat, to educate, the migrant communities, to better their own living conditions, for example. I don't think anybody looks at that. We only look at the problem once it happens. Say, for example, healthcare. Healthcare is provided only when the individual gets sick. But we are not really targeting the urban slums to do prevention of any kind of diseases or whatever. So are these some of the things that we want to take into effect? Also, the migrants not only face economic hardships, they are also vulnerable to greater social and health challenges, right? And so the unorganized sector is helpless. They are not built to be able to cater to something like this, right? And so their support is very limited, and in some instances it's not even available. So what does one do? And there's always a discussion about migrant men's health issues, which pose further economic challenges, right, to their families back home, because they're dependent on these migrants to send money back, whereas they themselves are not having 2 square meals a day. How is it possible for them to help those who are waiting, for some kind of support back home? So this really highlights the importance of urban health, the relevance of government and civil society investment, and also what is the cost of inaction to vulnerable migrant populations. Are we the ones who are going to face the brunt of it? Thank you.
Thank you, Dr. Samikan. And with those thoughts, and I think just to add to what you have said, I think these conversations or these webinars or discussions actually become extremely critical. So we will look forward to having another discussion with all of you together very soon. And on that note, I want to just take the opportunity to thank our esteemed speakers. I know Dr. Rao was unable to join because of a parallel commitment that came up at the last minute. We missed him, but I'll share the video with him. It's been an honor to have you with us. And as we all collaborate to see how to turn the tide of the epidemic and ensure security to the most vulnerable, it is time to invest more in healthcare and a robust social protection system that supports the most vulnerable. Internal migrants are key income generators that play a vital role in Indian society, and hence their health, well-being, and security should be a prime concern for all of us to come together for. On the note of leaving no one behind, thank you so much and have a very good evening.
Thank you.
Thank you. Bye-bye.